مروة.
مرحبا يا بروف.
السلام عليكم، جاهزين؟
عليكم السلام ورحمة.
الصور
أيوة
جاهزة؟
جاهزين، الصوت واضح والصورة واضحة. أيوة
السلايد
أفتحها.
جاهزات؟ السلايدز جاهزات؟ الو.
أي جاهزة السلايد، أشغلها هسه ولا شوية؟
لا. Okay, let us start this lecture on Sunday. It's tropical medicine and infectious diseases. And we skipped the last Sunday lecture because of the Eid. كل عام وأنتم بخير. Today we are going to talk about a disease, which is an old disease known for centuries by human race, and it involved many patients. Some of them are in high position like kings. One of those kings is Baldwin the Fourth, and he was king of Jerusalem in the 1174, and he was admired because he worked hard for his people despite the disabling disease, which is then was not known, but it turned out to be leprosy. So our lecture today is about leprosy. And leprosy is a very disfiguring, disabling disease of mankind. And fortunately, now we are in an era where we are looking forward to elimination of this disease by good science, good research, and good human effort. So this is leprosy. And I would like to start with some of the pictures which was kindly donated to me by Dr. Nabila Radi, who is one of the great women of Sudan, has been dedicating her time to the poor. Arwa, if you can see the slides. Are we showing the slides? Okay. This came first. This is nine-banded animal, the nine-banded animal which harbors the bacteria of leprosy, which is Mycobacteria leprae, and the animal is called armadillo nine-banded species, and this is the only animal which harbors the Mycobacterium leprae. Okay, we would like to impress the listeners about the picture, almost the end stage or the advanced stage of the disease just to have in mind how disfiguring and how disabling this disease. Next slide, please. So this is yes, here in the clinic in Mayo in Sudan, and this is a clinic of Dr. Nabila, and you can see this man who is standing, showing his both hands with a lot of amputation. The fingers are just the stumps of fingers of both hands, and you don't see the face. The face, the nose, that of a sudden nose, and his eyes are affected as well. This is why he's wearing glasses. But you can also see those who are sitting. One of them is showing his hand. Also, it is with a lot. Yes, this is his hand with a lot of amputations of the fingers. So this is one aspect of this disease. Second slide, please. Yeah, this is the disease affects skin, nerves, nose, eyes, and this is the whole lot of this disease. It affects other organs, but rarely, like testicles and other areas. But the main is skin. It's a disease of skin, and it is a disease of neurology. It affects the nerves, kills the nerves, and the nose is affected, and the eyes are affected. This is why people go blind with leprosy. Next slide. So this is a badge, which the badge is hypopigmented badge, a round badge, well demarcated. You can see the edge of this badge, and it appears commonly in the buttocks and extremities. The most important differential of this badge from other differential diagnoses is that this badge is anesthetic. It's anesthetic. If you pinprick or light touch on this badge, the patient will not feel. So it is an anesthetic badge on the skin, and this characterizes this badge from other badges of the skin, which we will come to when we talk about differential diagnosis. Next. This is a lady who had what we call leonine face, and these are nodular swellings of the ears and of the face, and this is what stigmatize the patient and make people run away from such patients and from the families where they live. Next. Taking time. Next slide. Okay, so these are the eyes, and the right eye is affected greatly. And here, the eye is what we call lagophthalmos. Lag meaning behind, lagophthalmos. And the sign here is the eye cannot be closed, on blinking. It remains open. So this is the lagophthalmos, and it's a very dangerous situation because with the affection of the trigeminal nerve, which supplies the cornea, the ophthalmic division of the trigeminal nerve supplies the cornea, and the cornea is very sensitive to outside trauma. So normally, if we go in a dust or somebody blowing in your eye, then you blink. But if you lose the capability and capacity to close your eye, then the cornea will be affected and traumatized and corneal opacification. The condition is made worse because in leprosy, the trigeminal nerve is affected, ophthalmic division is affected, And if the ophthalmic division is affected, the sensation, and it can respond to any reflex. Okay, so this is lagophthalmia or lagophthalmos, which is failure to open the eye when need be. Next. Okay, there are other problems with the eye, especially in the anterior part of the eye, iridocyclitis, the red eye there, the iridocyclitis, which causes, glaucoma in one way, photosensitivity, meiosis, the pupils becomes small, and cataract ensues and blindness. So it's the disease usually affect the eye. Usually affect the eye. Next, please. Okay, more of those. Lagophthalmia, they cannot close the eyes. Next, eyes. Yes, and here it's outside the nodule and affecting the eye. And yes, here the eye is gone with a lot of inflammation. If you look at where the iris is completely disorganized, and the eye is being lost. Next. Okay, here is Nabila, and I'm showing this picture because I would like to greet her from a distance, because she has been working day and night in saving eyes of the lepromatous patients. Okay, thank you. Let's go back to the lecture. Okay, the important part is this is a disease, clinical disease, which involves the skin, as we said. It involves the nerves, it involves the nose, and it involves the eyes. And we have seen some of these presentations. The disease is, as I said, stigmatizing, and Rasul sallallahu alayhi wa sallam استعاذ من هذا المرض عندما قال عليه السلام اللهم إني أعوذ بك من البرص والجنون والجذام ومن سيء الأسقام. So, والبرص is albinism. It's absence of melanocytes in the body, and the person becomes so white, and the hair becomes, grayish or golden, and there is even the eyes are affected. So the patient is albino, and it is autosomally inherited recessively. Okay, so she said that the camera. Is it working now?
Not yet.
Not yet?
Not yet, yeah, Prof. أيوة كده. Now it's working.
Okay, so the albino is an recessively inherited disease, and it's one of the miracles of Sayyidina Isa alayhi salam. كان يبرئ الأكمة والأبرص. والأكمة المولود بblindness, he was born blind. والأبرص, the albino. I'm saying this because some of the people would think that Sayyidina Isa was treating or يشفي الجذام. ولكن these are two congenital diseases, albinism, which is البرص, and الأكمة again is congenital, and treating the congenital disease is much more difficult than the acquired diseases. This is why we tend to think that these are the patients whom Sayyidina Isa treated. Okay, and it is very clear from Hadith of Rasul sallallahu alaihi wasallam قال اللهم إني أعوذ بك من البرص والجنون والجذام. الجذام هو leprosy. معناتها أنه the two diseases are separate. والله أعلم. Anyway, the disease is caused by a bacteria, and the bacteria is called Mycobacterium leprae. And you remember we have other Mycobacterium species, almost 190 of them, but the three which are the all stigmatizing is Mycobacterium tuberculosis. It causes tuberculosis affecting any part of the body. And then Mycobacterium leprae is another stigmatizing disease. And then the third is Mycobacterium ulcerans, from ulcerans, and from causing ulcer, and it is Bruley's ulcer. It's called Bruley's ulcer, capital B-R-U, Bruley's ulcer. And this is again is a mycobacterium which is just disfiguring, causing big ulcers in the legs, mainly, and other parts of the body. So Mycobacterium ulcerans is a third mycobacterium, and mycobacterium are they are acid alcohol fast bacilli. They are bacilli which is stained with alcohol acid fast. They're Nielsen stain, okay, and they are called myco because they have characteristics with fungi. Okay, they have a thick wall, and the wall contains mycolic acid, and this myclonic acid is hydrophobic, meaning that it's the bacteria can get cultured in where there is fluid, and this is similar to fungi. So it's gram acid Nielsen acid alcohol fast bacillus. So how is it contracted? If we look into the body in a patient who has promatous leprosy, and this is where the patient has fulminant leprosy, meaning that the bacteria is almost everywhere, the bacteria can be recovered easily from the nasal mucosa or nasal secretions, and also from the skin. So we get it from the nose, and if you have any contact with a patient with secretions from the nose, and then this is one of the areas where the portal entry is going to be again into the nose of the recipient. The skin can contain a lot of bacteria, billions of bacteria. Okay, and we have a slit or a slit skin, whereby we puncture the skin, okay, without causing blood, without squeezing blood, and then we squeeze the skin, and then the juice which comes out contains bacteria. At any rate, there is billions of bacteria in 1 gram of tissue, but most of these bacteria are killed, and so those who stain are the living bacteria. Okay, so what about contact? If I'm in contact with a patient with leprosy, we have to state that many patients who contract leprosy has not been in contact with any patient with leprosy. So how they contract the disease is not very clear. More so, patients or individuals who are in constant contact, okay, may not get the disease. But we have to put it straight that the chance of people who are in contact with a patient with leprosy is 10 to 15 times those who are not in contact. So the contact with leprosy patient is one of the factors which can contract the disease. There is doubt if there is any infection transmitted through the skin. Up to now, we have the evidence that the infection is transmitted from the nasal secretions, and individuals healthy individuals can contract the bacteria also through the nasal mucosa. Having entered in the body, the disease goes through the blood system first. They go into the body, the blood supply, lymph nodes, and then it goes to small arteries which supply the nerves. And they, at the entry of the artery to the nerve, they damage that area and they get into the nerves and they travel then centripetally to the Schwann cell, SCH, Schwann cell of the nerves, and they multiply there. Why they have this inclination or predisposition of going there is not very clear. But the Schwann cell harbors the bacteria and allows multiplication to the extent that it bursts. The Schwann cell bursts, and then more bacteria are distributed all over the nerves. Okay, in the nerves it causes a granuloma, which is very famous granuloma, and then the inflammation of the nerves will damage the nerve. So one of the cardinal features of this disease is loss of sensation. Loss of sensation in the area which we have already shown, the depigmented or hypopigmented area with loss of sensations for pinprick and touch, and peripheral loss of sensations like stocks and gloves, loss of sensation. So this is most marked. And if you see a patch on the skin, okay, well demarcated in the body or in the face or in the buttocks, where this is the commonest areas of the patch of lepromatous of leprosy, then test by a prick, by a needle, prick the area, and if the patient doesn't feel, then this is almost certain that it is leprosy. So the loss of nerve function is the factor which lead to disfiguring and disabling. Why? Because if you lose the sensations of the upper limbs or the hands, then self-caring about touching hot objects or fire or boiling water is deterred. You can't feel. If you don't feel the heat, you don't protect yourself against the heat or the fire. And this is why there is trauma, which is not being felt, burn, which is not felt, ulcers, which is not being felt, and they go into infection. And then pieces of the fingers come out, and this is self-amputation. And then we end up with that figure of the small of the hands being amputated in the most of the fingers. This is mainly because of loss of sensation. In the nose, there is infection, as we said. It comes from the nose, it goes to the nose. So the nose is a port of entry, okay, and port of discharge. Here you can have ulcers in the bridge on both sides of the mucosa, and then perforation and collapse of the bridge of the nose, giving you the saddle type nose. And the saddle is serrage, so that is the nose which is dipping in the middle, which is not a very attractive nose. So that is sudden nose is again due to the perforation and collapse of the cartilage, the mid cartilage. Okay, so the great success of mankind, I think, in controlling leprosy. Up to 1982, we used to have some drugs, okay, but in the 80s, it was very clear that we can have beautiful, very careful drugs, less toxic, and they can result in cure. So in this lecture, I would like to emphasize the fact that leprosy is a curable disease. And the number of patients who have been cured from 1985 to time is more than 14 million patients who have been completely cured of leprosy. Still, there are some countries reporting, including Sudan, but the major countries which are reporting leprosy cases is India, Brazil, and Indonesia. But still, it's a tropical disease which need to be looked at very carefully and be treated, because there is modern treatment, and the treatment is so easy that can be given once a month, and for 6 months or for 12 months. Then that is the beauty about it, with very little side effects, and it is curable. The important part of this notion is that it has to start early in the disease. So early diagnosis is the key. If we diagnose patients very early, then starting treatment, then there will be no neurological deficit, no skin disease, no nose affection, and no eye affection. What really characterizes the disease is the immunity of the patient. Okay, we know that disease, the appearance of a disease, or the clinical appearance of any disease, is the resultant battle between the body trying to overcome the disease or overcome the bacteria or whatever, or the virus, and the virulence of the disease or the virus. So it is a balance. But here in leprosy, it is very clear that the outcome of the disease is very much well determined by the body response or susceptibility of the patient to the bacteria. Those who have very strong cellular immunity, then they will contain the disease in certain parts of the body. And if you look for the bacteria, you cannot find the bacteria easily. And this is what we call tuberculoid leprosy. And this is very much restricted to the skin and nerves, okay? So the nerves is destroyed because of the reaction or interaction and the granuloma which can be formed, but the disease is contained. Versus where cellular immunity is weak, this is another spectrum which is called lepromatous leprosy. Lepromatous leprosy. Here you can find the bacteria almost everywhere in abundance, and you find florid manifestation like nodules of the skin, eyes, and the rest of it, because there is very little cellular immunity. What about humoral immunity? Humoral antibodies are seen with lepromatous leprosy. They are not protective. They are just an indication of the presence of the bacteria. So if you have very high cellular immunity and the patient gets leprosy, then they get the restricted high immunogenic patient with tuberculosis. If there is no restriction of the immunity, then the bacteria will swarm all over and become, virulent, and the patient will suffer from the bacteria more than others. This is why when we talk about treatment, those who have tuberculosis leprosy, we give them 6 months treatment, while those who have lepromatous leprosy, which is multibacillary, meaning that there is a lot of bacilli in the body, then we need to give them for 12 months. So clinical pathological manifestations of leprosy very much depend on host response, host immunity response. Okay, so that is essential in the understanding of the pathology, okay, of leprosy. And so what will happen? What will happen to the tissue? Okay, what is the pathology? What is the histological pathology here? The bacteria will come, and then will be sheathed by histocytes, dermal histocytes in the skin, sheathed. More bacteria comes, and these histocytes become epithelioid cells, and these epithelial cells is now covered by lymphocytes, and they cause a granuloma. This is where the immunity is high, okay, cellular immunity is high. It is contained in a granuloma with very little bacteria inside because it's being killed by the high immunity. But granuloma itself, when it grows in a tissue, it destroys the tissue. So if it is in the nerves, this severe granuloma formation will destroy the nerve, and the nerve will be devoid of function. And in a sense, we are controlling the bacteria, but at the expense of damaging the tissue of the nerves. Okay. In the other part, which is less immune, which is lepromatous leprosy, then we don't form a proper granuloma. The granuloma is loose with an overriding of bacteria in that small granuloma. Okay, so that is very important in the understanding of leprosy, the immune response to the bacteria. Okay, so what are the predisposition of patients to tuberculosis? Okay, like many other diseases, this is a chronic infection and has a very long incubation period. So it goes up to 11 years. So this bacteria can be there, all right, without any evidence, for so many years. It keeps itself there. And I think at this time, it is mainly reflecting the battle between the bacteria and the immunological reaction of the body, So the start of the bacteria, when it becomes clinical, because in the incubation period, we don't see manifestations, but it starts as an indeterminate stage in children. Indeterminate meaning we don't know what's going to happen to the clinical picture. Okay, what's going to happen to the outcome of the disease. So the indeterminate meaning we don't know which direction it goes. So if it can be self-limiting, the bacteria can be killed very quickly, and the skin changes are light, then they go out and resolve completely. So self-limiting infection can occur, number one. Number two, if the immunity is very high, it can go into the tuberculoid or the high immunity type. Or if the immunity is low, the cellular immunity is low, then it goes to the other end, which is the lepromatous. Between these two, there is a borderline, what we call borderline tuberculoid, borderline lepromatous, and borderline. But don't worry about that. If you know the poles, the two poles on the both ends, then that is what matters. Okay, and then if it goes from there, then it goes into granuloma, and the skin changes and the neurological changes. Okay, we knew that the skin changes, the patches, and the patches is, because this is early, people get scared about these patches, especially if you pinprick it and the patient doesn't feel, that is the moment where the patient will feel extremely depressed, because other lesions which very similar to the lesion of leprosy, like pityriasis rosea, lichen planus, psoriasis, versicolor. These are changes, the hypopigmented areas, all right, in the skin, but they are not anesthetic. They are not anesthetic. So once you pinprick the area and becomes anesthetic, then the patient, feels very, very much depressed. And there are books written about the emotion of patients and the discrimination against these patients. I read a book about leprosy patients being selected from Greece, and shipped to an island which is called Leprosy Island or Leper Island. And people, in the clinics of Greece, once they go there with a badge, and they look at the doctors, and once he says, this is leprosy, then the world falls on one's head. And they are extremely shipped or immediately shipped to the village or to the island. Okay, this continued in many parts of the world, not in islands, but in colonies, what we call leprosy colonies, all right? And we have quite a number of leprosy colonies in Sudan, in the Nuba Mountain, in South Sudan. It used to be near Wow. And even in Khartoum, there are leprosy colonies. And they formulate these colonies for two reasons. Reason one, they wanted to be together. Okay, they're patients, they serve each other, because the community and the society do not accept them. That's number one. Number two, people encourage them to be by themselves because for fear of contracting the disease. And if you go to the mosques in many parts, like Khartoum Mosque, you can feel people who have amputated fingers, begging, with the nose being saddled and the eyes red. And the patient loses the hair of the scalp and the hair of the eyebrows and lashes. This is very characteristic. Having said that about the skin, let us go to the nerves. Which are the nerves which are mostly affected? The top is posterior tibial. The second is ulnar nerve. And then the third is lateral popliteal, or what is called common peroneal nerve, which is, located behind the fibula, behind the head of the fibula. Okay, and then other nerves, cranial nerve, facial nerve is one of the notorious in leprosy, and trigeminal nerve. And we have already discussed the lethal combination of facial palsy with trigeminal palsy, because you cannot close the eye, and you cannot open it wide, and the sensations goes with the trigeminal nerve, and that will expose the cornea, which is a very sensitive area, to trauma and pacification and loss of vision. Autonomic nerves are also affected. And this will lead to scaly dry skin, because if you lose the autonomic nervous system, then in that particular part, in that area, then you become dry, you don't sweat. Okay, so if the lesion is dry, it becomes scaly because of the lack of autonomic nervous system and because of the lack of sweating. Okay, so these are the nerves. So if you want to examine for the nerves, you examine for the superficial nerve, which is here, like posterior auricular on the side of the neck, okay? And then feel for the ulnar nerve, it's very easy to feel here for the ulnar nerve. All right, lateral popliteal is again, you feel for the nerve. And here you can find the nerve very thick. So the cardinal features is hypothetic or anesthetic patch of the skin and thickened nerves and loss of sensations peripherally in the gloves and stocking pattern. Okay, so this is the clinical features of the nerves. Okay, thereafter, apart from these two, the eye, you already dealt with the eye. You have the lagophthalmia or lagophthalmia, ophthalmia, so you can't close your eye. And the open eye with no sensation in the cornea is prone to trauma. Okay, synechia, iridocyclitis, small pupils, cataract, all these can happen in the area. So remember, lagophthalmos is one of the cardinal features of eye affection in leprosy, and then posterior synechia, which will cause destruction of the anterior eye and lead to blindness. Okay, peripherally, obviously, if you don't feel, you can have ulcers, trauma, bleeding, and you can have bone affection, because this may go into the bone and cause osteomyelitis, and this usually hypoanesthetic or anesthetic area can fall easily out. Okay, so the bone can be affected. Okay, the metacarpal is smaller, it becomes smaller. Trauma will affect the bones, osteomyelitis, okay, and osteoporosis. So the bones can be very much well affected. Okay, there is an affection of the testicles with orchitis and hypospermia. And this is not very common, but it can occur. The kidneys are also said to happy to show some changes, but it's not very well documented. It's accepted, but at the best, it's rare. So let us restrict our clinical picture to the skin, mucous membranes, or especially of the nose, nerves, eyes, okay, and less with other tissues, particularly testicles. Okay, so the important part of this lecture is all about the pathology, which is very much dependent on the immunity of the patient and reaction to the bacteria, and then the various clinical features depending on how strong the immunity is, and the disabling disease is because of the anesthesia, mainly because of the anesthesia and the destruction of the cartilage and the bones and the affection of the eye. Okay, so what is the treatment? The treatment is early detection. And this is, and WHO, as I said, have in 1991 declared that they wanted to eliminate leprosy. Unfortunately, the word eliminate was not correct and has to be changed later, because, countries are not reporting because for fear of not doing well health-wise. But once it's open to a decrease of a remarkable decrease of number of cases, then people became, cooperative. So now the world will record about 150,000 cases a year, maybe, which is still high for a disease which can be effectively controlled. And the diagnosis is very clear. If you have a patch in the skin, this is early. Then you feel for the nerves. Then for the nose, you can have secretions from the nose, and then you go and culture it. No, you go and stain it. It's as far as culture is concerned, up to now we cannot culture the leprae, Mycobacterium leprae, but we can grow it in mice, and you know that armadillo, nine-banded armadillo, which is the animal which I showed you earlier, harbors the leprae, and this is offering a research, immunological research, and pathological research. So, and then after the nose, we can go to the skin by slit, dermal slit, small cut without bleeding, then you squeeze, and then you get the tissue out, and then you can get the bacteria in that area. But you should be aware that, you know, if you have very heavy immune response, like in tuberculosis, you may find no bacteria because the bacteria has been controlled, you know, killed and squeezed. So the response is no bacteria can be seen. However, the lepromatous leprosy, especially with the nodules all over and here, the ears and the lobe, is a very fashionable area for leprosy, very preponderity, inclination for the lobe of the ear. So you can get smears from there very easy, slitty smears and squeezing it and then color it. Okay, as far as serology is concerned, there is an antigen. There is an antigen of what is called antiphenolic glycolipid 1. There is an antigen in the bacteria called antiphenolic glycolipid 1 antigen. Okay, and this antigen, now we can have antibodies for this antigen, and this is very sensitive. We can say that this is for sure there is that amount of bacteria. So the level of the antibodies will determine the level of bacteria in the body. So that is diagnosis better by finding the bacteria, but can do by serology, okay? But mainly it's a clinical, as I have emphasized, that it is a clinical diagnosis, very much a clinical diagnosis, because the features of the hypoanesthetic, the sickness of the nerves, and the anesthesia, peripheral anesthesia, and then the ears and the lobe, the nose, the saddle node, and the eyes are very characteristic of leprosy. We don't need quite a lot of hassle trying to find the bacteria. Okay, so what is the improvement in our understanding and treatment? Okay, this is a disease which is curable. I would like to say it again. This is a disease which is curable. Okay, provided that you diagnose it early and you start treatment. And the treatment now, according to WHO, is the triple or multiple treatment, MDT, okay, multiple drug therapy, MDT, multiple drug therapy, of 3 drugs, okay. The one which is the bactericidal for Mycobacterium leprae is rifampicin. Rifampicin is the drug number 1. Okay, and this is, you remember, is an antibiotic which is extremely useful in Mycobacterium tuberculosis or tuberculosis lungs and others. It's very effective, okay, but here again it is effective. It is given once a month. And if you give it one dose and you measure the bacterial load, you will find 99.9% reduction by 1 month. Very rapid eradication of the bacteria. So rifampicin is a very valuable drug, and we owe a lot to rifampicin in the control of leprosy. Okay, the other drug is dapsone. It's dapsone, D-A-P-S-O-N-E, dapsone. Okay, dapsone is a drug which is old. We used to use only dapsone before the recommendation of WHO. And before the discovery that rifampicin is so strong in treatment of leprosy. Okay, so dapsone is a sulfone, synthetic sulfone, like sulfonamides. So what is the role in treatment of leprosy? It prevents resistance to rifampicin. So it's an adjuvant drug which will help rifampicin to work better and retard the resistance to rifampicin. So that's number 2. And then we have clofazimine. Clofazimine. C-L-O-F-A-Z-A-M-I-N. Clofazimine. Clofazimine. Okay, and clofazimine is a relatively safe drug, which again is given with rifampicin. And the dose is like follows. It's not a normal dose, but it's like follows. Number 1, you give rifampicin 600 milligrams every month, full stop. Okay? 600 milligrams orally, rifampicin, every month. And then you give dapsone. Okay? And then you give clofazimine. In dapsone, we give 300 milligrams, and then 300 milligrams every month, and 50 milligrams daily. Okay? And clofazimine, we give again 300 milligrams, okay, for 6 months. If it's called paucibacillary or multibacillary, pauci meaning paucity, a small amount of bacilli, then we give for 6 months. Otherwise, we give for 12 months. All right, we have 5 minutes to finish. But anyway, rifampicin is an antibiotic which is very well tolerated. As you remember, it is an enzyme inducer. It's a very strong enzyme inducer. And so interaction with other drugs is important. In the other drugs is important. Okay, but as a drug, it can cause redness, brownish red, tears, saliva, and sweat, and urine. They become red. This is, some people call it the red drug, because it changes these secretions into red. The second thing is they can cause hepatitis, and this is again has to be noted. Okay, and relatively safe. It's a relatively safe. Okay, with clofazimine. It's unfortunate that we don't write it. We should write it, at least the students should get acquainted to the spelling. So clofazimine is causes increased pigmentation, but otherwise it's very safe. Okay, dapsone is one with side effects. Common side effects. Okay, number 1 is hypersensitivity. And this hypersensitivity to dapsone could be seen as exfoliative dermatitis, fever, and hepatitis. Anemia can occur, but hemolytic anemia can occur and become severe in patients with 6G6 dehydrogenase, glucose 6-phosphate dehydrogenase deficiency. And as I said in the last lecture of hematology in the tropics, glucose 6-phosphate dehydrogenase is very common, and it causes bleeding, or it causes hemolysis under favism, which is broad beans, and with some drugs. And one of the drugs is dapsone. Okay, dapsone can cause hemolysis if the patient is deficient of glucose 6-phosphate dehydrogenase. Okay, it's very easy, but the complexity is you have to give the treatment, like once a month, once every day, and so on. This will give you the difficulty in compliance, but the patients are very well motivated. The patients are motivated to take the drugs because the disease is very disabling. Prevention can occur with BCG. BCG, remember, this is the vaccine against tuberculosis, BCG, which is given now almost routine to children. It also prevents Mycobacterium leprae infection. So, in conclusion, this is an old disease, it is a discriminating disease. It is an stigmatizing disease. It causes skeletal abnormalities, particularly amputation of the hands, okay, disfiguring of the face, like the sudden neck, sudden nose, swelling of the ears, leonine face, like bumps and nodules all over. And it's a disease which can cause a lot of neurological abnormalities because it has predilection to the nerves. Okay, luckily the treatment is easy and available, and now is being dispensed free of charge for every patient. We need to have a campaign, or we have a setup where we can deliver the antibiotics with dapsone and clofazimine to the needy patients wherever they are. Either they are in mukhayamatum, or they are in an isolation or leprosy camps. So with that, we are telling a story of success. A story of success, a disease which has been very prevalent, now is coming down to talking about eliminating it, okay, from the globe because of the strong antibiotics. So that is Mycobacterium leprae, and with that I would like to conclude this lecture. Thank you very much.